pressure against the retina also. So you have to lift it up. So we lift it up and start to chew it using the be soft technique, we call it. Right hand is using usually the forceps because this is the one that you have to chop it up. Left hand is usually holding the lens in the middle of the eye with suction. Very low cutting rate, to 23 gauge, something like 200, and that's, you have to reverse it, and you have to remove all the vitreous that's around it, because if you have left any vitreous while you're pulling and pushing, then you might end up with another detachment. And now you have to crush it between your hands, divide and conquer. You see, it's becoming a technique now by manual crushing the nucleus. And if you need to, you can use phaco emulsification, but it's very dangerous in the retina. I don't like it either. And I think if I can avoid it, I try to avoid it all the time. The other issue is perfluorocarbon. You wouldn't inject perfluorocarbon in an eye like that because the retina is opening the mouth to chew perfluorocarbon behind it. So there's no perfluorocarbon for this. Usually I'm not using perfluorocarbon because perfluorocarbon, when you start cutting the nucleus, it doesn't stay behind. Particles are sitting above, and then they go behind the perfluorocarbon. So perfluorocarbon is actually blocking the particles by pushing them against the retina. So I'm trying to avoid using perfluorocarbon also. So I give you the whole piece by piece to show you how little space you've got. You should not touch the retina detachment. You should not go anteriorly. You should not go posteriorly. You should stay in the middle and make it to small pieces. Another thing that people ask me is when they have particles that they throw against the retina, what's going on? Nothing. If they go them by themselves and they hit the retina, they do nothing. If you push them or touch them while they're sitting on the retina, you make tears, you make bleeding, you make pigment dispersion behind the retina. So don't touch anything that's sitting in the retina. Suck it, bring it in the middle, and then chew it up. Otherwise, you are in trouble. And at the end, you need a little bit of patience. You finish up and you're left with a retina detachment that's the easiest part, okay? To fix a retina detachment. But see the space, and the complication possibly started because he put the 23 gauge stroker in the wrong position, something like 6-7 millimeters behind the cornea. And another issue is that these people that they have complications, they have a lot of anxiety, you need to change the local anesthesia, you need to explain them that it's going to take much more time because you have an accident. They need to know under local to do that. And that's about it, and we can discuss it, but the thing that I'm always saying to my doctors, you are not allowed to fish anything that's behind the iris. When you have particles behind the iris, let them be. We'll do it. And put the lens. Don't be afraid to put the lens. If you clean the anterior chamber and no vitreous, and if you have a ledge to put a lens, put the lens, and we can remove everything from the back of the eye. Because the patient that has a lot of viscoelastic in the eye, probably the next day he has a white cornea with 60 millimeters of pressure. And this is what you like to avoid. Don't inject a full amount of viscoelastic into the eye because you cannot remove it from the posterior chamber, and this is going also to raise the pressure. And you have the next day you have a painful eye, white cornea, and a patient who would like to kill you. Because you promised me a 10-minute surgery, and then you go home driving. And you got this result. Thank you very much for accepting me.
Do you have any experience with such cases, rare cases?
Yes, I have experience in retinal detachments with ranunculus, but I don't have any experience with the nucleus behind the. I have silicone oil behind the retina, but this is first time I see this by Dr. Tanasas. Thank you for this nice presentation.
I think same here. I've not had any experience of the lens behind the retina, but we often see patients with drop nuclei and detachments. So, Dr. Thanos, can you just describe how the procedure is done again? What is the forceps you're using in the other eye?
Due to reasons that your voice coming back to me, can you repeat the question without the microphone? No. What forceps? Always 23. 23 forceps. My nuclear surgery is always 23. 25 doesn't work. And remember, a very good tip is use your good hands to hold the forceps and the bad hand to hold the vitrectomy machine, because the vitrectomy does do a lot. So instead of supporting it with a light pipe, which is bending, another issue, if you bend the light pipe, then you cannot find a new one. So use this. Use forceps on the right hand, and vitrectomy on the left. The vitrectomy thing is low cutting rate, very big suction. You keep it in the middle of the eye, and then you squeeze it again. It's like force feeding. You squeeze it with the forceps, and the forceps are using two ways. When you close the forceps, they become knife, and you cut something soft. When you open and close, you chew them. So there's another trick to do that. Those small tips are unfortunate, happen because we have hundreds of cases like that. Because of my age. So don't grow up too quickly. Well, I'm using for these cases always silicone 5700, because I want to be sure that they will not have another complication. Gas can go behind very easily. Silicone oil, the hole doesn't have the surface tension to put silicone oil behind, because things are going behind when the surface tension of the hole is bigger than the surface tension of the thing that you're injecting. So you can use silicone oil freely, and then you can remove it and have a patient that you have a lens and everything like that. There's a lot of tricks and tips. That's why we made this TVRS school, Thessaloniki with the Retinal Summer School, we do, because you cannot find them in the internet. This discussion cannot be in the internet. People are always, and they have a sign above my office, I'm not studied in Google. I have not studied in Google. A lot of people are opening the internet and they try to learn surgery. It's helpful tool, but the most helpful thing is what you're doing here. And being there with a Karsten is going to be next July. And he's going to sit on top of you and tell you, don't do that, don't do that. And those tips and tricks by you to other people are the one that make surgery great.
Thank you very much. Please,
okay, thank you so much. I'm conscious of time. I'll just move on to the important slides. So just for the cataract surgeons hearing us here or seeing us here, this is when you have a shallow C and high pressure, this is what you need to think of. Is it a problem from pressure on the globe, so it's an external factors, or we're dealing with suprachoroidal hemorrhage, or we're dealing with aqueous misdirection, and it has to be in this order. So here, in this case, what actually the problem was that the drape was full and was pulling on the eye. Then the other one is suprachoroidal hemorrhage, and the message here I just want to give is do not do anterior vitrectomy, because what would happen is that the suprachoroidal hemorrhage is going to rupture if you do anterior vitrectomy. So the best thing to do is close, close, close. And then if it's not this or that and you examine the fundus, if you can see well, then it will be aqueous misdirection. And here you can do anterior vitrectomy if you need to, if you're not sure, close. For the sake of time, I just want to focus mainly on this. Suprachoroidal hemorrhage, you don't need to drain them unless it's very large and is painful, or the pressure is super high, or the kissing choroidals because the retina is going to adhere together. So this is the old way of doing it, where you make the cuts and AC maintainer. A newer way is, as we all know, is using a trocar. Here, this is an exudative suprachoroidal effusion, but the same for hemorrhage. and use a trocar. And if you go about 7 millimeter back, you get better drainage. But I want to show you a very cool technique that I learned from one of my colleagues, which is really very cool, because these eyes are difficult, especially when you have very big hemorrhage. And this technique I'll show you here in a minute. Dr. Michael, he's now in Rwanda, he was in the UK. But this is really very nice when you have big hemorrhage, what to do. So what they did is, in the preoperative area, they injected TPA 50 microgram, 0.1 mil, 7 millimeter, just with a needle. So you have this patient in the preoperative area, you inject that, going 7 millimeter with a 30 gauge or a 27 gauge needle, and you inject. And then you wait for 2 hours, you can go ahead and do a case or two, and give them Diamox for the pressure, which is going to go up more. Then here the TPA liquefied the blood, so it becomes very easy. So you do then an AC maintainer and a trocar, and it comes out very quickly. And I think this is very clever technique, because it really makes things very simple, liquefies the blood. And we all know that these cases are difficult. And that's his video. And I'm waiting for the case to do that, but I think this would be a very nice way of doing it. Thank you so much. I will conclude here for the sake of time. Thank you. And thank you so much to our panelists and to the floor. Thank you.